Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. This episode features the personal experience of a pharmacist who underwent medical and social transition. It is part of a larger educational program entitled Multidisciplinary Approach to Ensure Inclusive, Compassionate, and High-Quality Healthcare for Transgender Individuals. During this podcast, pharmacist Olivia Buckoski will share her transition story along with advice for healthcare professionals caring for transgender individuals. She covers many topics, including the importance of educating all members of the care team about the needs of transgender individuals, adherence considerations with hormone therapy, and examples of uninformed care. For more information on this topic, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear about Olivia's experiences.
Hi, my name is Olivia Buckoski, and I'm a 38-year-old transgender woman and pharmacist, and I'm going to speak a little bit about my personal experiences transitioning. My transition included a period of social transition outside of the workplace for approximately 1 year. I then started my medical transition, which consisted of an androgen blocker and the feminizing hormone estradiol, at which time I was presenting as a transgender woman full-time. After a year on hormones, I underwent what's commonly known to as bottom surgery or gender affirmation surgery in June of 2020, and in the following year, I underwent facial feminization surgery in November 2021. As I said, I began transitioning socially in 2017 and 2018. This period included experimenting with wearing new, feminine clothes and beginning the process of facial hair removal by laser and electrolysis. I had not started presenting as a transgender woman at my workplace during this time. In the spring of 2018, I began seeing a gender-affirming therapist and preparing to medically transition. This includes hormone replacement therapy. In the fall of 2018, I reached out to a local primary care physician and made an appointment to start hormone replacement therapy. I chose a clinic that said they used the informed consent model. This supports the patient's right to personal autonomy in choosing care options without the required involvement of a mental health care professional. This is compared to clinics following the standard model set forth by WPATH, standards of care that require a letter from a therapist. This letter would note confirmation of diagnosis of gender identity disorder, assessment and discussion of patient's expectations, assessment of patient's mental health, assessment of any other psychological comorbidities, and that the patient has or will have adequate psychological and social support during treatment. The informed consent model is important to provide equitable care to transgender individuals. Many transgender individuals cannot afford the cost of mental health care, which can be upwards of $200 for a single therapy visit. Some therapists may also require multiple visits to obtain a letter to start hormone replacement therapy. My expectation at my primary care physician visit was that I would receive a prescription for hormone replacement therapy and schedule a follow-up for labs to track my hormone levels. Instead, my experience ended up illustrating the need for education across the entire healthcare team on the needs of transgender individuals and how to cultivate an inclusive, compassionate healthcare environment. I had canceled my appointment twice, once from the parking lot before I had the courage to go into the clinic. I had not legally changed my name yet, so my medical insurance and chart were still under my dead name, which is the name I was given at birth and traditionally considered masculine, but that I no longer use. When the nurse came into the waiting room to get me, she called my dead name and my heart sank. I was dressed in a new black dress, had my makeup done, my nails painted, and the first true purse I could call my own a hand. I finally stood up. The eyes of everyone in the waiting room were on me, and I made my way to the back. I had such high hopes while I was waiting. I was finally taking a big step in my transition and already felt crushed. I was second-guessing my clothing choices and felt that this was not going as I had expected. This also isn't just about my personal discomfort at the moment. There's also a safety issue, as I do not know the acceptance levels of anyone in the waiting area and who could be waiting for me in the parking lot now knowing that I'm a transgender woman. This experience really hits home that it's crucial that everyone on the care team needs to be educated on the needs of transgender patients. This starts with the person who checks in the patient for their appointment and continues to the nurse who brings patients back to the exam room. All healthcare workers should be aware of the basics, such as preferred name, preferred pronouns, and privacy. After finally making my way into the exam room, I was ready to get my first hormone prescription. I was met with more disappointment. The primary care physician started my exam by asking if my hair was real or a wig. This is an emotional trigger for me because I've always been concerned with balding and hair loss. Instead of focusing on my healthcare needs, I was now self-conscious about what was wrong with my hair and if it looked like I had a wig on. A million thoughts were racing through my head, which were irrelevant to my reason for being there. This was a vulnerable time in my transition, the start where my body was changing, along with how I presented to the world. My advice to healthcare professionals providing care to transgender patients is, don't ask questions that are irrelevant to the transgender patient's care at the time. Don't comment on a transgender patient's body unless it is relevant to their care. Many transgender patients can be extremely self-conscious about their bodies because they underwent a puberty process inconsistent with their gender identity. During my appointment, the primary care physician noted that I would need a letter from my therapist to begin hormone replacement therapy, even though I was initially told they were an informed consent clinic. The prescriber noted that he had just recently joined the practice and that the other two practitioners used the informed consent model, but he did not as of yet. I left that day heartbroken, feeling that I needed to change healthcare providers and start the entire process over again. I had wasted my time, emotional energy, and money. Several weeks later, I arrived for the second appointment with the same primary care physician. I had my therapist's letter in hand. I was again dead named in the waiting room, but I left that day with a prescription for spironolactone and estradiol. Later that day, I went to the pharmacy to pick up my hormone replacement therapy prescriptions, only to experience another hurdle. I was told that the pharmacist needed to speak to my primary care physician because my gender marker was male and I was being prescribed female hormones, despite the fact that I was clearly female presenting and told the pharmacist I was transgender. Pharmacies are also very public spaces and many times do not have adequate locations to discuss things privately, which is a reason all pharmacies should have private counseling rooms on site. Finally, the next day, I was able to get my prescription. The first one was for one estradiol tablet 4 times a day, and the second was for one spironolactone tablet twice per day. As anyone who's taken prescription medication in tablet form knows, taking prescription medications more than once or twice a day can be exhausting to remember. Missing doses or having to double up the next dose can lead to mood disruptions, hot flashes, and disrupt the early bodily changes seen during transition. Several months after being on hormone replacement therapy, I went to my primary care physician for my follow-up and to have my hormone levels checked. I was dead named again in the waiting room. My estradiol level was well below the female range at approximately 100 picograms per milliliter. Preferably, it should be approximately 300 picograms per milliliter. My primary care physician decided to increase my estradiol prescription to 2 tablets 4 times daily. This is an even larger number of tablets to take in a day, and is difficult to carry that many tablets with you throughout the day. This only increases the likelihood one will be less compliant and hormone replacement therapy will be less effective. At my second follow-up appointment several months later, my estradiol labs were still well below normal, and I asked my primary care physician about starting on injectable estradiol. I wanted to start injectable estradiol, which can have advantages in some patients compared to the tablet form of estradiol. Injectable estradiol commonly only has to be given once per week, and it also bypasses first-pass metabolism in the liver, commonly leading to higher estradiol levels. In response, my primary care physician said that he was new to prescribing hormone replacement therapy, and he only felt comfortable prescribing the tablet form of estradiol. He also noted that I would have to inject myself with a needle, as if this was a reason not to make the change. Many patients inject themselves with medication daily, for example, insulin in diabetics. I also regularly give injections in my role as a pharmacist, and I did not see injecting medication as a barrier to starting injectable estradiol. Instead of making excuses, my primary care physician could have educated himself or referred me to another healthcare provider at the practice with the necessary knowledge to provide me with the healthcare that I needed. Simply being willing to treat transgender patients is not enough. Practitioners need to keep up to date on best practices. I left that appointment and continued on my current dosage. Several months later, when I returned, my labs were still well under target, and I was not seeing the bodily changes I was expecting to see, such as breast budding and fat redistribution. My primary care physician essentially said there was nothing he could do, as I was on the max dosage of estradiol tablets he was comfortable prescribing. In response, I stopped going to that practice and asked my trans-informed therapist to suggest another prescriber. I found another prescriber, and the experience was what I had hoped for when I began my medical transition. At my first appointment, I was not dead named in this office, because they give every patient in the waiting area a colored slip of paper, and the nurse simply calls that color. No one in the waiting area then knows your name or the reason that you are there. My new primary care physician was obviously educated on transgender healthcare by referencing the University of California San Francisco guidelines for transgender healthcare. He also knew that some patients cannot achieve adequate estradiol levels simply on tablet estradiol alone, as I had mentioned to my first primary care physician. He prescribed me injectable estradiol at my first visit. Within 3 months of being on injectable estradiol, I had normal female blood levels of estradiol, and my breast growth had doubled, and I had noticeable fat redistribution to my face. It felt amazing to have a positive and affirming primary care physician who was on my side and making sure my transition went smoothly and was effective as possible. It is recommended I go every 6 months to my dermatologist for a skin cancer screening due to a prior skin cancer diagnosis from before my transition. Pre-transition, my appointment would simply involve removing my shirt and pants and the dermatologist checking my moles. At my appointments following my transition, I was asked to take off my shirt and pants as I had normally done, but felt exceptionally exposed, covering my breasts with my arms. I later found out that women are typically given modesty gowns during exams, but I was never proactively offered one until I had my name legally changed nearly a year later, at which time I changed my name and gender marker with my insurance carrier and at my practitioner's office. Another example of uninformed care is that I've had to take multiple pregnancy tests prior to x-rays for my confirmation surgeries. I have also been asked multiple times when my last menstruation was. I've insisted multiple times that I'm a transgender woman and have zero chance of pregnancy. This illustrates the need for training and policies for transgender patients. There's also issues regarding medical records. Now that my gender marker is female, I commonly receive email and phone reminders concerning a need for a pap smear. These only serve as a constant reminder that I'm different. Medical records need to be updated to reflect the diverse number of genders and their specific medical needs. Insurance has been a nightmare for myself and can be a nightmare for transgender individuals. Gender markers, legal versus preferred names, procedures not matching gender assigned at birth, questionability around cosmetic versus medically necessary procedures. Healthcare staff and billing departments need to be well trained on issues to avoid problems before they occur. I've had numerous issues both at the pharmacy and with hospital billing departments during my transition. These problems include billing codes not matching my gender and CPT codes being deemed cosmetic. It is demoralizing to think that you have everything in place for your gender confirmation surgeries to be covered by insurance, only to receive a surprise bill for tens of thousands of dollars while you're trying to recover. Transitioning is expensive. Just imagine the cost of having to replace your wardrobe, or needing laser and electrolysis treatments to remove all the hair from your face, or weekly voice lessons. Don't make things worse for your transgender patients by not educating yourself and your staff on best practices and working with your transgender patients to obtain coverage for their medications and procedures. I would like to end by reiterating a few points. Don't ask questions that are irrelevant to the transgender patient's care. Appointments are not a time to go fishing for personal curiosity and asking questions not related to the transgender patient's care. Listen to patients. Transgender patients tend to be very educated on the transition process and are valuable resources in your personal growth as a transgender-informed practitioner. You can learn from them. Educate yourself through CEs and reach out to local organizations for in-services and best practices. Consider joining or creating a local transgender healthcare network or journal club. As a final comment, there is no shame as a healthcare professional in realizing that you do not know enough about LGBTQ or transgender healthcare. Many schools don't even offer this curriculum. I only graduated from pharmacy school about 10 years ago, and we didn't have LGBTQ curriculum in my pharmacy education. On that note, I do encourage you to educate yourself now, because a little bit of knowledge can go a long way in creating a compassionate and inclusive healthcare environment.
Thank you very much, Olivia, for sharing your personal experience and advice. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, Multidisciplinary Approach to Ensure Inclusive, Compassionate, and High-Quality Healthcare for Transgender Individuals from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.